Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Imagine completely disconnecting the human stomach, like literally removing it from the body and then having to physically rewire the intestines directly to the esophagus just so a patient can safely digest a meal.
It is a pretty wild concept when you really step back and look at it.
It really sounds like science fiction. But for a surgeon performing a total gastrectomy, I mean, it is just a standard Tuesday in theater.
Yeah, exactly.
So today we are tearing down the blueprint of gastric resections. I feel like the tendency, especially when you are studying, is to view every single variation of this procedure as a completely different beast.
Right.
Like you are trying to memorize 10 distinct surgical instruction manuals for, your distal resection, your total, your proximal.
And honestly, treating them as these isolated, unrelated procedures just creates a massive, unnecessary cognitive load.
Oh, for sure.
The anatomical reality is actually far more organized. We're looking at a surgical landscape that relies entirely on a deeply shared anatomical foundation. And, once you map that out, the overwhelming complexity really starts to fade into a highly logical sequence of clinical decisions.
And that sequence is exactly what we are mapping out on this deep dive. Whether you are a surgeon scrubbing in and prepping for theater, or a doctor aggressively revising for your board exams, or you are just simply looking to refresh your surgical anatomy on your commute, this walkthrough is specifically tailored for you.
We want to make it intuitive.
Exactly. Our mission is to systematically detail the operative steps of gastrectomy, establishing that universal shared trunk of access, and then pinpointing the exact moments where the techniques diverge based on, the pathology and the extent of the resection.
Right, where the road forks, essentially.
Yes. But before we pick up the scalpel, we have a mandatory clinical disclaimer. This content is strictly for reference and educational purposes only. You must always follow local guidelines, hospital protocols, and of course, your own clinical judgment in your actual daily practice.
Absolutely. Every patient's anatomy and every local unit's protocol presents unique variables.
So true.
But the most robust framework for conceptualizing gastrectomies is really to view them as branches of the same tree. There's this universal trunk of access and vascular mobilization.
Okay.
And from that foundational trunk, the operation branches off, depending on what exactly you are treating, which culminates in a distal, a total, proximal, or even a sleeve resection.
Okay, so let us unpack that shared trunk. It starts with basically securing the perimeter, right?
Yes.
Before a single piece of gastric tissue is removed, the abdomen has to be accessed and the anatomical battlefield surveyed. The approach, it might be an open midline laparotomy from the xivicisternum down past the umbilicus.
Or it might be a minimally invasive laparoscopic or even robotic setup with ports arrayed across the upper abdomen.
Right. But the immediate next step, particularly when the indication is oncological, is always a meticulous physical exploration. You are manually running the small bowel, inspecting the liver surfaces, the peritoneum, the greater omentum, and really diving deep down into the pelvis.
Yeah, because this exploration is functionally an on-table staging maneuver. You are looking for any peritoneal seedlings or liver surface metastases or just unexpected direct invasion into adjacent organs.
Because if you find something there, it changes everything.
Exactly. Committing to a massive physiological disruption like a gastrectomy is completely futile if there is unforeseen disseminated disease.
Wow, yeah.
So once you have visual and tactile confirmation that the tumor is actually resectable, then you transition to mobilization. The stomach is essentially an embryological pouch, and it is slung between two mesenteries.
Like a hammock.
Exactly like a hammock. And your goal is to systematically disconnect those ancient tethers. You begin by elevating the greater omentum and dissecting it off the transverse colon through that avascular plane.
And that specific move is what drops you straight into the lesser sac, right? Giving you full access to the posterior wall of the stomach.
Yes, that is your entry point.
From there, you are marching up the greater curvature. You take down the gastrocolic ligament, and as you get higher, you encounter the gastrosplenic ligament. And this is where you are actively dividing the short gastric vessels.
Right. And in a major resection, you are taking those attachments all the way up to the left crust of the diaphragm. Surgeons are often using modern ultrasonic or bipolar energy devices to seal and cut those vessels really efficiently.
Makes sense. And then you flip your attention to the lesser curvature, opening the gastrohepatic ligament to expose the caudate lobe of the liver and the right crus of the diaphragm.
You are systematically isolating the organ from its blood supply and the surrounding structures. It is exactly like you said earlier. You are clearing the perimeter of a building before deciding which rooms to demolish.
I love that analogy.
By setting up these safe zones and identifying critical structures early, you gain the complete circumferential visibility you need for the next, arguably most critical, oncological step.
Which brings up a great point. Is this initial clearing phase the exact moment where the operative pathway sharply diverges based on whether we are dealing with benign or malignant disease?
It is. That is exactly where the fork in the road happens. If a surgeon is operating for, say, a severe, complicated, non-healing, benign ulcer, the regional lymph nodes are largely left alone.
Right, because there's no cancer to hunt down.
Exactly. The focus is purely on safe tissue removal. But a diagnosis of gastric adenocarcinoma transforms the entire objective of the surgery.
So what changes?
The lymphadenectomy becomes the defining feature of the operation. You are no longer just removing an organ. You are meticulously hunting down microscopic cellular spread. And this dictates whether you perform a D1 or a D2 lymph node dissection. A D1 dissection involves clearing the perigastric nodes directly attached to the lesser and greater curvatures, essentially the nodes in stations 1 through 6.
Okay, but a standard D2 dissection, which I know is the oncological gold standard in many regions, that is vastly more extensive, right?
Absolutely. It is a completely different ballgame.
A D2 dissection requires a surgical level of aggression that is just incredible to visualize. You aren't just snipping away loose fat, you have to physically strip the adventitia and lymphatic tissue completely off the major blood vessels of the celiac axis.
Yes, you are skeletonizing the common hepatic artery, the splenic artery, and the left gastric artery.
That sounds intense.
It is. You have to trace the left gastric artery all the way down to its exact origin on the celiac trunk, ligate it flush at the base, and clear out all the surrounding nodal tissue in stations 7, 8, 9, 11, and 12.
And doing that deep in the retroperitoneum, I mean, the tactile reality of that must be highly demanding.
It requires sweeping the lymphatic tissue en bloc with the stomach while avoiding catastrophic injury to the fragile, high-pressure vessels you are leaving behind. 1 millimeter of miscalculated energy device application on the celiac trunk can result in a massive, immediately life-threatening vascular emergency.
Right. So, okay, the perimeter is heavily secured. The stomach is circumferentially mobilized, the lymph nodes are swept up in block, and the primary vascular routes are controlled. Let's look at how the procedure adapts when the pathology report indicates a localized tumor in the distal part of the stomach.
Okay.
A subtotal or distal gastrectomy is the surgical answer here, aiming to resect the antrum and distal body while sparing the upper stomach. But the mechanical challenge is freeing up the duodenum to make that first cut. This requires a classic Kocher maneuver, right?
Yes, the Kocher maneuver is essential here. To perform it, you incise the peritoneum along the right lateral border of the second part of the duodenum. By doing this, you enter in a vascular retroperitoneal plane that allows you to physically lift the entire duodenum and the head of the pancreas off the retroperitoneum, sweeping the inferior vena cava posteriorly.
Oh, wow.
Yeah, this maneuver gives you the crucial anatomical slack and mobility needed to safely manipulate the duodenum. Once it is mobile, you identify your distal margin, which is usually a few centimeters past the pylorus, and transect the duodenum using a linear stapler.
Stapling across the duodenum seems structurally precarious if you are too close to the pylorus or, if the tissue is inflamed from a nearby tumor or ulcer. Surgeons have to ensure they do not compromise the vascular supply to that remaining duodenal stump, right? Especially if they plan to close it off permanently later.
That is a critical point. Tissue health is everything.
So once the distal end is free, you move to the stomach side. For a distal cancer, the proximal transection line is typically drawn straight across the mid-body of the stomach.
Correct.
The surgeon applies a linear cutting stapler, completely detaching the diseased distal portion. And crucially, in an oncological operation, those cut edges are immediately sent off to pathology for a frozen section analysis, while the patient is literally still on the table.
Yeah, the frozen section is a non-negotiable safety checkpoint. The pathologist rapidly freezes, slices, and examines the tissue under a microscope to confirm there are no microscopic cancer cells at the resection margin.
And if there are?
If the margin is positive, you must go higher. You take more stomach until you reach clean, healthy tissue. Once you have confirmed negative margins, you are left with a functional gastric remnant hanging from the esophagus and a transected duodenum below.
Right, so the disease is gone, but the continuity of the gastrointestinal tract is completely broken.
Exactly. Now you have to rebuild the plumbing.
Rebuilding the plumbing. So looking closely at the reconstruction options following a distal gastrectomy, 3 historical methods really dominate the literature. We have Billroth I, Billroth II, and Roux-en-Y.
Let us break those down.
Let's do it.
Billroth I, mechanically speaking, is a straight gastrojejunostomy. You are taking that gastric remnant and anastomosing it directly back to the freshly cut duodenum. It is highly appealing because it perfectly mimics the natural physiological pathway of food.
It does. But while it is physiologically elegant, it is anatomically unforgiving.
How so?
Well, a Billroth I demands a highly mobile, completely healthy duodenum that can reach the stomach remnant with absolutely zero tension.
Ah, I see.
If you have just performed an aggressive resection for a bulky distal cancer, you have likely sacrificed too much length and local tissue health to make that direct connection viable. Forcing a Billroth under tension is a guaranteed recipe for an anastomotic leak.
And a leak there is disastrous.
It carries a staggering mortality rate.
Right. That limitation basically forces surgeons to abandon the direct route and look at Billroth II. Now, this is a gastrojejunostomy. Instead of struggling with the duodenum, the surgeon permanently stapled the duodenal stump closed, leaving it as a blind-ending pouch.
Then they grab a mobile loop of the jejunum from further down the small bowel, bring it up, and stitch or staple it directly to the stomach remnant. It completely bypasses the fixed duodenal problem entirely.
It solves the tension problem beautifully, but it introduces a severe physiological flaw.
Bile, right.
Exactly.
Yeah.
In a Billroth II, the bile and pancreatic enzymes that empty into the blind duodenal stump travel down the jejunum and wash directly across the new anastomosis.
Yikes.
Yeah, they're dumping straight into the exact same loop where food is exiting the stomach. This creates a massive risk for chronic alkaline bile reflux.
And bile washing up into a gastric remnant, or worse, up into the esophagus, is highly destructive. The mucosa simply is not engineered to handle that constant alkaline chemical burn.
Not at all.
Over the years, it causes severe gastritis, excruciating pain, and even malignant transformation, which is terrifying. And this brings us to the Roux-en-Y reconstruction. This is essentially, rerouting the house plumbing to completely bypass that messy backflow issue. You are building an entirely new diversion system.
So sorry for the interruption, but this is important. We need your support to help us grow, reach more surgeons, and keep delivering cutting-edge surgical content. Press the support button and donate now if you like what we do. Let's get back to the podcast.
The fluid dynamics of a Roux-en-Y are just brilliantly designed to protect the upper GI tract.
Walk us through it.
So, just like in a Billroth II, you permanently close the duodenal stump. But then, you travel 20 to 40 centimeters past the ligament of Treitz, which is the suspensory muscle where the duodenum transitions into the jejunum.
Okay.
And you completely transect the small bowel. You literally cut it in half. You take the distal cut end, which we call the roux limb, and bring it up to anastomose to the stomach remnant.
Yeah.
So all ingested food now travels straight from the stomach down this dedicated roux limb.
But wait, the bile and pancreatic juices are still draining into the proximal half of the jejunum that you just disconnected? How does that work?
Right. To manage those digestive juices, you take that proximal limb and anastomose it into the side of the roux limb, creating a jejunostomy.
Okay, forming the Y shape.
Exactly.
Uh-huh.
But the physical location of this connection is everything. You must make this connection 40 to 60 centimeters downstream from the stomach.
Downstream. Okay, why so far?
By enforcing that long physical distance, you create a gravity-dependent drainage system that prevents the bile from ever refluxing high enough to reach the stomach or the esophagus.
Oh, that is so smart.
Yeah, the food travels down one branch of the Y, the bile travels down the other, and they only mix half a meter away from vulnerable mucosa. Roux-en-Y is a much more complex anatomical puzzle, for sure. But functionally, it is vastly superior for the patient's long-term quality of life.
So we have solved the reconstruction problem for a localized distal tumor. But what if the pathology report shows a diffuse aggressive cancer spreading high up the lesser curvature, or, say, a tumor sitting squarely in the proximal cardia?
Yeah, a subtotal resection will not cut it there.
Right. The surgeon has to take the entire stomach. Transitioning to a total gastrectomy completely changes the magnitude of the operation.
A total gastrectomy requires you to push that initial mobilization to its absolute anatomical limits. You are taking down all the short gastric vessels and fully clearing the left crus of the diaphragm.
Everything has to go.
everything. You divide the right and left gastroepiploic vessels, the right and left gastric arteries at their roots, and you sweep every associated lymph node basin. The stomach is completely freed from its blood supply in its bed.
And then you have to control the esophagus. Dissecting the distal esophagus deep within the diaphragmatic hiatus is, well, it is a tight, challenging space.
Very tight.
If this were a benign condition, surgeons would painstakingly try to identify and preserve the vagus nerves running along the esophagus to maintain downstream bowel motility. But in the setting of gastric cancer, the vagus nerves are almost universally sacrificed to guarantee clear oncological margins.
You cannot risk leaving disease behind.
Exactly. So the surgeon passes an umbilical tape around the esophagus to gain traction, pulling it down slightly into the abdomen and transects it. The entire stomach is removed in one piece.
And what you are left with is a transected esophagus retracting up into the lower mediastinum.
Which sounds terrifying to reconnect.
It is a challenge. To rebuild continuity, we rely on the Roux-en-Y configuration again, but this time we are performing an esophagojejunostomy. You divide the jejunum, create your roux limb, and bring it all the way up to connect directly to the esophagus.
Okay, but reaching the lower mediastinum with a loop of small bowel seems physically impossible without introducing massive structural strain. Tension seems like the ultimate enemy here. Pulling the jejunum all the way up through the diaphragmatic hiatus sounds incredibly precarious. How do surgeons ensure this new junction does not just immediately pull apart and result in a catastrophic mediastinal leak?
A leak at the esophagojejunostomy is literally one of the most feared complications in general surgery.
I can imagine.
To combat the tension, surgeons have to carefully lengthen the mesentery of the roux limb. They actually hold the mesentery up to the operating lights to transilluminate it.
Oh, to map out the blood vessels.
Exactly, mapping out the vascular arcades. They meticulously divide specific inner arcades to gain physical length while strictly preserving the marginal vessels that run along the bowel wall.
So they are uncoiling it.
Precisely. The bowel must reach the esophagus and sit there naturally, with zero downward pull. If there is even a millimeter of tension, or if that transilluminated blood supply looks dusky or compromised, the anastomosis will fail, necrose, and leak.
Wow. And once they have that tension-free, well-perfused reach, making the actual connection deep in the hiatus usually relies on precision engineering. This is where the circular stapler comes into play, right?
Yes, doing that by hand is incredibly difficult.
So you secure the anvil, which is the metal cap of the stapler, tightly into the open stump of the esophagus with a purse string suture. Then you introduce the main body of the stapler into the roux limb of the jejunum. You mate the spike of the stapler to the anvil in the esophagus, click them together, and fire.
It is so satisfying.
It punches out a perfect, uniform circular anastomosis and lays down concentric rings of titanium staples all simultaneously.
It really is a remarkable piece of surgical technology that provides consistency in a very anatomically hostile environment. Once that esophagojejunostomy is secure, you close the enterotomy where you inserted the stapler, and you complete the reconstruction with the jejunostomy 40 to 60 centimeters distally, just as we did in the distal gastrectomy.
Allowing the biliopancreatic secretions to finally mix with the food bolus.
Exactly. It is a masterclass in respecting tissue perfusion and mechanics.
It really is. Okay, so having covered the major oncological resections, we must also address procedures that preserve more of the natural anatomy when a total removal isn't mandated. For instance, if the cancer is caught very early and is strictly localized to the proximal upper stomach, surgeons might perform a proximal gastrectomy.
Right.
They resect the cardia and fundus, but preserve the distal body, the antrum, and the pylorus.
And preserving that distal stomach is great because it maintains a reservoir for food and preserves the pyloric sphincter, which regulates emptying.
But reconnecting the esophagus directly to the remaining stomach and esophagogastrostomy is physiologically problematic, isn't it?
Yes, very. By removing the proximal stomach, you have destroyed the lower esophageal sphincter in the angle of his.
And that is the natural anatomical flap valve that prevents reflux.
Exactly. Without those structures, the remaining acidic stomach contents just shoot straight up into the esophagus. So to prevent this, surgeons often splice a small, isolated segment of jejunum between the esophagus and the gastric remnant.
Acting as a functional buffer zone to protect the esophagus from acid exposure.
You got it.
That mechanical manipulation brings us to another highly common but conceptually entirely different procedure, the sleeve gastrectomy. Primarily used in bariatric surgery for weight loss, the goal here isn't oncological clearance. You aren't transecting the bowel or building new anastomoses to reroute fluids.
No, the sleeve gastrectomy is purely a restrictive procedure. The surgeon starts about 4 to 6 centimeters proximal to the pylorus, preserving the emptying mechanism. They then use a series of linear staplers to divide the stomach longitudinally, marching straight up the greater curvature all the way to the angle of His. This removes about 80% of the stomach volume.
Wow. But this stapling isn't done blindly, right? The surgeon passes a sizing tube, usually a 36 French bougie, down the esophagus, through the stomach, and into the pylorus.
Yes, the bougie is crucial.
You are using that thick tube as an absolute structural template. It is a hard boundary against the lesser curvature. You staple right up against it to ensure you leave a narrow, uniform, high-pressure tube of stomach without accidentally stapling the lumen completely shut.
That would be bad.
Very bad. But because the staple line is exceptionally long and the pressure inside that new sleeve is very high, strict leak prevention is critical here too. Surgeons often use staple line reinforcements or carefully oversew the line to prevent blowouts.
Right. And really, regardless of whether you are finishing a sleeve, a proximal, a distal, or a total gastrectomy, the final phase of the operation involves universal safety checks. You are systematically checking for hemostasis. You are performing intraoperative leak tests, perhaps submerging the anastomosis in irrigation fluid and injecting air via an orogastric tube.
Looking for bubble.
Exactly, looking for bubbles. Or injecting methylene blue dye to visibly ensure the staple lines are completely airtight.
But there is a massive long-term anatomical risk generated by moving all this bowel around, particularly in those Roux-en-Y reconstructions we talked about. You have divided the jejunum, pulled limbs up through the mesocolon, and entirely bypassed the duodenum. By doing this, you have created entirely new, unnatural geography inside the abdomen.
You have.
So what needs to be done to the mesentery before a surgeon even considers closing the laparotomy or port sites?
Ah, you were referring to the creation of mesenteric defects. This is a highly tested, literally life or death surgical concept.
Yeah.
When you bring the roux limb up to the stomach or esophagus, you inherently create unnatural anatomical windows or gaps between the newly rearranged mesenteries. The most notorious of these is Peterson's defect, which is the space created between the mesentery of the elevated roux limb and the transverse mesocolon.
And the small bowel, constantly undergoing peristalsis, is essentially a coiled snake, always looking for a place to slide into.
That is a perfect way to picture it. If you leave these new mesenteric defects open, loops of small bowel will eventually find their way into those gaps. They can slip in, become trapped, and twist, leading to a catastrophic internal hernia.
Oh, man.
This causes complete bowel obstruction, strangulation of the blood supply, and rapid necrosis of the gut.
And the terrifying part is that this can happen months or even a decade after the initial successful surgery, right?
Yes, the risk never really goes away if it is not closed.
Yeah.
Therefore, the absolute non-negotiable safety step before closure is to meticulously locate and close every single mesenteric defect with non-absorbable sutures.
You have to seal those traps.
You must. Only when the anatomy is secured do you proceed to close the fascia and skin.
The ultimate success of these procedures really comes down to respecting the physical engineering of the human body, even as you are radically tearing it down and rebuilding it. It is absolutely fascinating how this deeply complex set of surgical options all stem from that singular, shared trunk of embryological mobilization and vascular control.
It really is.
Branching off based on the pathology, but always culminating in the strict universal rules of tension, perfusion, and anatomical closure.
Viewing the operation from that macro perspective reveals its elegance. But, beyond the purely mechanical steps of removing diseased tissue and stapling bowel loops together, I think it is worth considering how drastically these reconstructions alter human physiology.
Oh, absolutely.
By completely bypassing the duodenum in a Roux-en-Y and creating new Y junctions half a meter down the jejunum, surgeons are fundamentally changing where, when, and how food, bile, and pancreatic enzymes mix.
We are rewriting the rules of the body.
Exactly. We are not just removing a tumor. We're actively forcing the gastrointestinal tract to completely relearn the complex, highly orchestrated biochemical process of digestion from scratch. It is a profound, permanent manipulation of human biology.
That is a staggering concept to mull over the next time you are scrubbing into a cyst or just trying to map out these pathways in your textbooks. Wow. Well, a huge thank you to everyone joining us on this deep dive.
Thanks for having me.
If you like this content and found it helpful for your clinical understanding, please do not forget to share this deep dive with at least one of your colleagues or friends to help spread the word. We really appreciate it. Also, check out our YouTube and other social media pages for more visual breakdowns, and be sure to check our previous season and episodes, which feature some very relevant topics to integrate into your clinical practice. Until next time, keep exploring the anatomy and stay curious.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.